Hello everyone, this is an introduction to the TAI treatment pathways concept. We'd like to introduce the concepts as a way to improve our awareness and ultimately shape our choices in the treatments we provide. We've got a strong belief that using and documenting these pathways will shrink the perception and the actual practice variation within physical therapy. When I say we, I'm specifically talking about myself, David Depler, Chris Hoekstra, and Bill Temmis. We could say there's even a bigger we, include our whole profession. Most of you will be thinking, this is actually what I was taught in school. And to that we say, hooray. If that's the case, then what we're asking in this presentation will hopefully be just a very small, yet comfortable and exciting shift for you. We've all read articles from mainstream publications talking of the discouraging practice variation within physical therapy. To the public, we often seem like a tangled mess of options and treatments. Although there may be different specific treatments, there generally is an underlying consensus when you look at these treatments. Unfortunately, it's not obvious to the customer or the payer. Let's face it, we all tend to treat to our strengths and interests. While some of us lean more towards manual techniques, others may lean more towards functional movement training. But we all agree the treatment should actually be based on the patient's needs and interests. This treatment pathway concept may actually help us develop and implement treatment closer to our collective ideals. We're talking about taking what looks like an 8-lane multi-directional highway down to a few lanes, all pointing in the same direction. We're not looking for one lane or one way of treating. Think of the pathways as categories or phases of treatment. The strength of this model lies in its simplicity and hopefully consistency with our current practice philosophy. There are 4 pathways that operate as a progression. We completely understand that rarely, if ever, will treatment be solely located in only one pathway on a given day. Still, at any one point in time, a therapist should be able to identify the primary treatment pathway being addressed, or it can be assumed that the treatment may lack focus and precision.
The inflammatory phase includes treatment we do to rest an area or facilitate cellular healing before activity and mobilizations. It includes things like bracing, rest, modalities, and mobilization of adjacent structure. It does not exclude systemic conditioning, but when this is performed, activities are selected that minimize or alleviate stress to the affected area. When the inflammation is low, we can progress to the segmental mobility phase. This term is broad to include joint mobilizations and manipulations, soft tissue work, local movement through exercise or activity, and even local or specific stabilization training. Here, your focus is on improving local or specific movement before you move on to a larger system integrated movement. The progression to improving functional movement patterns happens when the presence of the previous 2 pathways are minimized. In this phase, movement and strengthening of local and adjacent structures becomes integrated to restore optimal movement patterns. This is where we have the greatest ability to achieve lasting benefits of physical therapy. Still, clinicians may see minimal gains when this pathway is emphasized too early. The conditioning phase, the final conceptual phase of treatment pathways, is geared primarily at the injured worker needing to return to the physical demands of employment or that athlete looking to get an edge on training and competition. Most PT patients will only receive minimal treatment or education relative to this treatment pathway.
Okay, we completely understand that what we've presented so far is a simplistic approach, so let's add some layers of complexity to make the model a little more relevant. You can look at these layers of complexity as a filter of sorts to guide your actions. They include the patient's goals, interests, and expectations as one filter, and the patient's response to pain as the second filter. The response to pain will influence treatment options, sometimes even more than the objective findings and the patient's verbal request for treatment. A person with a maladaptive response to pain may benefit from conditioning-based treatments and general activity education before gains from the passive manual therapy of the segmental mobility deficits pathway. In order for this concept to become a practice that'll really reach its potential benefit, we need to create an easy structure to help you document the pathway. For now, we can offer a cut and paste paragraph that can be placed in the assessment section of any note. You can find this document on the portal. Just do a quick search for treatment pathway assessments. Here's a portion of the initial exam assessment template. It would read, at this stage of treatment, the patient will be placed in the blank treatment pathway and expected to progress through the blank treatment pathway. I anticipate roughly blank number of visits in this pathway before progressing to subsequent treatment pathways for a total of blank visits. It's very likely this template will be built into Athena Clinicals with drop-down menus and numeric entry options. Collecting data on the back end could be very valuable in helping us see, on average, how many treatments are needed in each pathway per condition. No doubt understanding this relationship to the clinical outcomes and patient satisfaction information will also be valuable. You can imagine that the patient's perception of variation of care would be minimal if therapists were in the habit of saying something like, first, we're going to decrease inflammation, then mobilize restricted structures, then stabilize things that are moving too much, and ultimately we're going to work to restore optimal movement. With the pathway system of treating and documenting, a payer will see a common progression of PT with an acceptable variation of care. If we use this process, we can determine average expectations for prognosis based on diagnosis, comorbidity, starting function, and the initial treatment pathway. Again, it's the actual and perception of standardized care that we need to convey. Last, and certainly not least, we can use this data to revolutionize the Care Connections clinical practice guidelines into treatment-based classification, strategically paired with a pathoanatomical model of dysfunction. And in this, we'll elevate the usefulness of the guidelines to the clinician and the payer. As we've said, this is likely a small shift in behavior that can have large implications to our actual practice and the perception of physical therapy. Making the mind shift to viewing your treatment as a progression in the treatment pathways process will help clarify the what, why, and when of our practice. It's a practice that comes from a mind shift facilitated by standardized documentation. In conclusion, let's summarize the takeaways. Number 1, start to think of the treatment you provide relative to these pathways. Ask yourself, what pathway am I treating in today? Next, if this concept feels natural to you, try the suggested templates in your assessment sections. And then lastly, give us feedback. We want to know how you're doing with this. Thanks, everyone.